So my name is Darren Kies. I'm an interventional radiologist and diagnostic radiologist for Piedmont South Imaging. RFA stands for radiofrequency ablation, and it is one of the thermal-based ablation platforms that we have available to us. Historically, it was the only heat-based ablation platform that was available, but in the last 10 years, microwave ablation, which is another heat-based ablative strategy, has basically replaced radiofrequency ablation in the United States. The main reason for that being is that it allows you to achieve higher temperatures and a larger ablation zone. So, in terms of answering this question, I will probably use the term microwave ablation more frequently than RFA, but they are two heat-based platforms that are designed to kill tumor. When it comes to treating liver tumors percutaneously with microwave ablation or RFA, tumor size is very important in influencing how you're going to treat the tumor. The second most important thing is location. So microwave and RFA are very effective at treating focal tumors that are generally 3 centimeters or less in size. And that was traditionally with RFA. Now with microwave, you can get ablation zones that are a little bit larger, and you can treat tumors that are kind of borderline 4 to 5 centimeters in size, depending on how you space your microwave antenna around. But the number that most people keep in mind is about 3 centimeters or less. As you try to treat these larger tumors, you have to understand that the chances of having a local recurrence will go up. The second most important thing is location, and location really matters because being a heat-based strategy, there are certain parts of the liver that you don't want to burn. Tumors that are very central in the liver, that are immediately adjacent to the main portal vein, the main bile duct, those are areas where you want to stay away, and really they are not accessible for radiofrequency ablation. With regards to how you decide on when you do percutaneous ablation versus when you do other local therapies, and those other therapies in general, just to put them in a nutshell, are going to be catheter-directed therapies, treatments that are delivered through the bloodstream. Trying to decide between the two is a little bit, there are advantages and disadvantages to both. And some of it, honestly, is based on the physician and where he was trained and what he's comfortable with, because they all work effectively. The way that I view the two, whether you're going to use an ablative platform or whether you're going to use some other form of local regional therapy, being an arterial-directed therapy, is that my feeling is that if you feel like you can ablate something, then you should ablate it, because ablative therapies have a better local control rate. There are ways that you can deliver Y90 through the bloodstream where the local control rate is almost as good as ablation, but there has been no studies that show that it is as good as ablation. So, so if you're trying to treat a tumor and you want to get the best oncologic outcome, and you think it's of the right size and in the right location that it can be ablated, my personal feeling is that's the best local therapy that you can offer that patient. If for some reason it's located in a place where you can't ablate it, or where or if it's too big and it can't be treated with percutaneous ablation, that's when you would choose another local therapy, such as chemoembolization or yttrium-90 radioembolization.